As promised, here in part 2, we will focus on the argument for euthanasia based on autonomy, as well as the distinction, or lack thereof, between killing and letting die. The argument from autonomy, also sometimes called the argument from self-determination, or the argument from dignity, is the most popular way to justify physician-assisted death or voluntary active euthanasia. This is something that Callahan points out at the beginning of his article. While there are many different forms this argument can take, a popular one is something like this. 1. A patient's right to self-determination justifies her refusal of treatment, including life-sustaining treatment. Basically, the idea here is that the reason passive euthanasia is justified is because it respects the patient's right to self-determination. 2. If a patient can rightfully refuse life-sustaining treatment, then she can rightfully choose her own death. This can often be defended in many ways. If we were trying to start from the assumption that passive euthanasia is justified, then this is what the claim would look like. But we could also just start from the assumption that a person has a right to kill herself, and claim that that is justified due to autonomy or the right to self-determination. Third, finally, if a patient can rightfully choose her own death, then respect for autonomy justifies a physician helping a patient die. Now, this conclusion is a bit weaker than some often put it. Many argue that respect for autonomy obligates the physician to help, rather than just justifies the physician in doing so if she chooses. Either way, the claim is that because I have the right to choose my own death, or the right to kill myself, then a physician can or may be required to help me carry out my own death if I request it. We will want to spend some time analyzing this argument, but I want to make two quick observations here. First, this argument itself does not give any reason to prefer only physician-assisted death rather than voluntary active euthanasia. If I have a right to choose my own death, then that doesn't seem to limit a physician's involvement to only giving me a prescription rather than injecting me directly. Second, this argument assumes in step 1 that the basis for the right to refuse even life-sustaining treatment is a right to choose one's own death or something else related to death. But the right to refuse treatment is often defended on the grounds that we have a right to refuse interventions into our bodies. If that is the case, then the argument for physician-assisted death or active euthanasia cannot be justified by appeal to the legitimacy of passive euthanasia, at least in this way. So a way to think about this is that the argument is setting up a choice to have life-sustaining treatment as option A, life-sustaining treatment, option B, death. So, in choosing option B, you are choosing death and therefore have a right to such a choice, assuming you have a right for passive euthanasia. But those who think that the right to refuse is based on a right to refuse unwanted interventions into one's body, the choice is more like option A, intervene with life-sustaining treatment. Option B, do not intervene with life-sustaining treatment. So, in choosing B, you are not choosing death at all, but merely a lack of intervention. Those are two important but shorter observations, but ones to keep in mind, especially if you're writing topic papers on this. But let's dig deeper into evaluating this argument. The first and most important step in evaluating this argument is part of the basis for Callahan's argument against physician-assisted death and active euthanasia, although he puts it in different words. As he says early on, the idea that we can waive our right to life and then give to another the power to take that life requires a justification yet to be provided by anyone. For him, the issue of euthanasia and physician-assisted death is not a mere matter of self-determination, since it requires the active involvement of at least one other person, other than the person wanting to die. This ties into a deep debate in philosophy around the concept of autonomy, and in particular in medicine, around whether respect for autonomy requires respect for negative autonomy or positive autonomy. Everyone agrees that respect for autonomy includes respect for negative autonomy, which is the freedom from interference. It is negative because all it requires on behalf of other people is to not get in your way when you're doing what you want to do, usually on the assumption that it isn't harming anyone else. So for negative autonomy, if I have a right to kill myself and I choose to do so, you respect my autonomy when you do not stop me, but you have no obligation or reason to help me actually kill myself. Also, in cases of medical refusal, if I choose not to be treated, then you respect my autonomy by not treating me. Respecting autonomy in the positive sense requires more from people, however. Positive autonomy includes a right to assistance in carrying out my free choices. It is positive because it requires someone to actually go out and do something to actually respect my autonomy. So for positive autonomy, if I choose to be treated, then you are obligated to treat me. Now this might sound fine at first, a doctor's obligation is to treat patients, but clearly we don't think this is always true. If a person comes to a surgeon and says they want their appendix removed, but there is no medical reason for doing so, certainly a surgeon can refuse to perform that surgery. More controversially, while in the U.S. women have the right to an abortion, that does not imply that they can just go up to a doctor and he or she is required to perform it upon request. Physicians can conscientiously object to some procedures, often they do in a case of abortion, as well as simply not doing any medical procedure just because it is asked for. But in the case of choosing to die, following positive autonomy, if I choose to die, then you are obligated to help me die. On this understanding, my right to kill myself implies a duty on the part of someone else to help me kill myself. But certainly we do not think that that is the case. If I do have a right to kill myself, that doesn't imply anything about someone else's duty to help me. So what is important about this distinction is that while negative autonomy is uncontroversial in general, everyone agrees it ought to be respected generally speaking, positive autonomy is much more controversial, and while there are some cases that most people agree are cases where respecting autonomy requires involvement, there are also many where most people agree that it is not disrespecting autonomy if one doesn't get involved. Furthermore, we need to evaluate the right to refuse treatment and the right to request aid in dying through this distinction between negative and positive autonomy. When we look at the right to refuse treatment and the right to die in the context of negative and positive autonomy, we see that there is an important difference between the two. Passive euthanasia is a matter of negative autonomy. This is very clear in the case where I have an advance directive that requires physicians not to put me on a ventilator. In that case, all that is required for them to respect my autonomy is to do nothing. The case of removing an intervention, such as a ventilator, that is already in place is a little bit harder to understand, since it looks like the physician has to do something, remove the ventilator. But this is still generally considered a case of negative autonomy, since to respect it requires you doing nothing. It just so happens that you are currently doing something, so you must stop what you are currently doing. Were you not already invading my body, then you wouldn't have to do anything. A similar non-medical case would be theft. I have a right of private property, which generally just means you can't mess with my stuff. But if you have already stolen something of mine, then my right to private property, which generally just requires doing nothing, requires that you return that item. So what is important is that negative autonomy does not mean there is never action done by others, but that the action is only required to get back to the point of non-interference. Physician-assisted death and active euthanasia, on the other hand, are matters of positive autonomy. I am requesting the physician take an action to help me carry out my action, and my choice requires the involvement of the physician to succeed. This is very clear in the case of active euthanasia, where my choice to die requires that the physician administer a lethal dose of a drug to me. Assuming I am incapable of killing myself, perhaps due to advanced ALS, then I literally could not act on my choice to die without someone's interference. The case of physician-assisted death is a bit more complicated, since I would self-administer the lethal dose of medication. So presumably I could just kill myself another way without any involvement from my physician. But in the case of physician-assisted death, I am requesting that my physician get involved in my choice to kill myself, and my choice to do so by means of physician-assisted death cannot be carried out without the involvement of the physician. So, if you think that respect for autonomy only requires respect for negative autonomy, or at least it doesn't clearly support respect for just any form of positive autonomy, then the argument from self-determination is problematic because it requires that respecting autonomy include respecting positive autonomy. And given these considerations, why think that respect for autonomy does require respect for at least some instances of positive autonomy? Well, one way this is often argued for is by appeal to the distinction between killing and letting die. Recall from the Code of Ethics for Nurses that at end-of-life situations, nurses were permitted to intervene to lessen suffering and other symptoms in dying patients, even if the interventions were known to likely bring about death sooner. However, they are not permitted to intervene for the purpose of bringing about death sooner. As many of you pointed out, there seems to be an odd tension here. If I inject morphine to control pain, but it ends up killing the patient, I have done nothing wrong. But if I inject the same amount of morphine with the goal of it killing the patient, then I have done something wrong. Similarly, as some of you have pointed out, there seems to be a tension between the idea that a physician can remove interventions from a patient, thereby resulting in the patient's death, but the physician cannot intervene in a way that brings about the patient's death, even if in both cases the patient has requested to die. While there is more philosophical work to be done in trying to understand the Code of Ethics position, part of the explanation, and one that is directly relevant for the distinction between passive and active euthanasia, is the distinction between killing and letting die. For those of you that have seen Batman Begins, Batman himself holds fast to this distinction. If you haven't seen the movie, then immediately stop the lecture and go watch it, because I might spoil it a bit. Towards the end of the film, with the train racing towards Wayne Tower, with Batman and Ra's al Ghul fighting in it, Batman seems to have the upper hand, but Ra's is convinced Batman cannot win because he will not do what is necessary. He will not kill Ra's al Ghul. And this is true, but as Batman makes clear, while he won't kill Ra's al Ghul, he doesn't have to save him either. And then the train goes careening off the broken tracks, presumably resulting in Raz's death. Batman did not kill Raz in his mind. He let Raz die by not intervening to save him. In the medical setting, passive euthanasia is often considered an instance of letting the patient die. More generally, letting die would be not intervening to prevent someone from dying. A classic example that is supposed to make you think letting die can still be problematic is the child in the pond case. You have let the child die if you see him drowning in a pond, but do not act to save him. Alternatively, active euthanasia and perhaps physician-assisted death, although less likely there, are considered killing a patient. More generally, killing the patient involves intervening or acting in a way that causes someone to die. So instead of finding the child in the pond that you just happen not to save, it would be like putting the child in the pond and ensuring that he drowns. The purpose of this distinction for those who support it is to argue that killing is more morally problematic, while letting die is not, or is less morally problematic at least. And the distinction serves two purposes in the debate over euthanasia and physician-assisted suicide. Those in favor of active euthanasia argue there really is no distinction, which is something Brock did in his article. Those opposed to active euthanasia argue that there is a distinction, and it divides morally permissible behavior from morally impermissible behavior, which is what Callahan did in his article. The other purpose it serves is to draw a distinction between physician-assisted dying and active euthanasia, as those who may be in favor of physician-assisted death but not voluntary active euthanasia will argue that there is a distinction between killing and letting die, and that physician-assisted death is not killing, but voluntary active euthanasia is killing. So let's examine some of the arguments Brock and Callahan make for their positions. Brock argues that there is no important moral distinction between killing and letting die. Removing life-sustaining treatment, just like providing an injection of a lethal dose of a drug, is killing. To support his argument, he asks us to imagine a case of a woman with advanced ALS who is on a respirator. Now, at the woman's request, the physician removes the respirator and the patient inevitably dies. This is a paradigm example of letting die, by most counts. But he asks us to imagine instead that the woman's greedy son comes in and does the same thing, knowing the woman wouldn't request it or the physician wouldn't do it, even if it was requested. Most people would assert that the son killed the mother, not that he merely let her die. As Brock points out, there are morally relevant differences between these cases, such as the issue of consent. But his point is that the moral difference is not that one was letting die and one was killing, since both did the exact same thing. And since it would seem wrong to claim that the son let the mother die rather than killed her, we should just admit that in both cases the woman was killed, by the physician in one, by the son in the other. He bolstered this point by trying to show that there are cases of letting die that we don't think are morally better than cases of killing, when all other factors are kept the same. In his case, he just uses the difference between not intubating a patient, who then dies, versus extubating a patient, who then also dies. So both are forms of passive euthanasia, and on most counts, both are not morally problematic. But in the case of extubation, the medical team did have to do something to cause the death. And so he thinks that's an instance of killing by any standard, whereas the case of not intubating is clearly a case of letting die. But both have the same moral standing. Finally, Brock further argues that part of the reason we may want there to be a morally relevant distinction between killing and letting die is because we assume that all killing is wrong, but that is simply not true. Sometimes killing is morally justified. And for Brock, cases of passive euthanasia, if they are morally justified, are simply morally justified killings. If all of this is true, then that means there may be cases of voluntary active euthanasia that are also morally justified killings. Those arguing against active euthanasia cannot, on Brock's view, use the claim that passive euthanasia is letting die as their defense of why passive euthanasia is morally permissible, but active euthanasia is not. Callahan, on the other hand, does think there is a distinction that is morally relevant, but that the debate has been confused because it has conflated two distinct ideas, causality and culpability. Causality, Callahan claims, includes the direct physical causes of death. Culpability, on the other hand, is a moral term and revolves around attributing moral responsibility for actions. For instance, a lethal injection causes death, but for Callahan, removal of life-sustaining treatment does not. More generally, Callahan thinks that causality and culpability are confused in three ways. First, when stopping treatment is considered causing death. As he says, stopping treatment can only result in death if there is already an underlying problem that will cause death without the treatment. But a lethal injection would result in death for anyone, healthy or not. So when I remove someone from a respirator who cannot live without a respirator, I have let them die, but when I have given someone a lethal injection, I have killed them. Because in the case of removing the ventilator, for a healthy person, that wouldn't be a problem. But for someone who is already ill or has a problem of another sort, removing the ventilator then can lead to their death. Second, he thinks that culpability and causality are confused when we fail to realize that judgments of culpability are human constructs. By this he means that we often confuse terms that are best applied to the natural world by applying them to our moral world, or vice versa. As he says, when physicians had, or now have, no ability to save someone from something, we don't hold them accountable for the death. But sometimes merely because there is technology or medicine to deal with a particular issue, we do hold them accountable. Finally, following from the second issue, is the fact that we often use the term killing in various ways that confuses causality and culpability. Killing, as a natural phenomenon, is a causal term, what physically caused the death. But we sometimes apply it to cases of letting someone die that we find morally objectionable. So if a physician negligently omits something that results in a patient's death, we want to hold that physician morally accountable. So we sometimes call the action killing. But this is a wider use of the word than it should be. It's in fact just a case of bad letting die for Callahan. What is interesting about Callahan's approach to the issue in comparison to Brock's is that both seem to agree that the distinction between killing and letting die in itself doesn't distinguish morally right acts from morally wrong ones. Both agree that cases of letting die, in the standard sense, could be morally objectionable, such as cases where the physician negligently omits a particular treatment. Similarly, both seem to agree that cases of killing, in the narrow causal sense, could be morally permissible. They differ, however, in that Callahan distinguishes two senses of killing, whereas Brock blends them together. Finally, whereas Brock sees a problem with holding the distinction, that we fail to see that some instances of killing are justified, Callahan sees a different problem if we don't hold the distinction. We will reinforce the view, among physicians and maybe the public in general, that when a patient dies, the physician is always morally and physically responsible for it, while this certainly isn't true. Sometimes they just cannot save a person no matter how hard they try. So we've discussed the various issues involved in deciding whether there is a distinction or not. I don't want to impose a view on the subject on you, but rather give you different considerations in both directions. For the purposes of your papers and further thinking on this subject, let's also think about how we could use the distinction for various arguments. In the first case, you could use the distinction between killing and letting die, or at least the understanding of killing that comes from it, to defend the view that while physician-assisted death is morally justified, voluntary active euthanasia is not. This is because in the case of physician-assisted death, the physician does not kill, in the physical or moral sense, the patient. The patient kills herself. All the physician does is provide the means. So, on this view, killing results in the unjustified death of another, and therefore is wrong, which is why voluntary active euthanasia is wrong, but physician-assisted death is not. A second way to deploy the distinction would be Brock's method. There is no distinction, and in fact, both voluntary passive euthanasia and voluntary active euthanasia are justified because both are instances of justified killing. A third way to use the distinction to argue that neither PAD nor VAE are justified because both objectionably involve the physician in a set of events that results in death. Following Callahan, you could think that removing life-sustaining treatment does not objectionably put the doctor into the course of events because removing the treatment only leads to death if the patient is already dying. But prescribing a medication, or actually injecting the patient, could result in the death of anyone, healthy or unhealthy. Therefore, both physician-assisted death and voluntary active euthanasia require an intervention on behalf of the doctor that constitutes morally problematic killing. So these are just various ways you could go on this subject by just deploying the distinction between killing and letting die in various ways. So where does this leave us? Certainly, it is the duty of all medical professionals to respect the autonomy of their patients. The question is, does such respect require the physician to aid the patient in killing herself, or to kill the patient upon request? In thinking of this issue more, especially if you are writing a topic paper on the subject, keep these sorts of considerations in mind. Does respecting autonomy require respecting requests to aid? I think it is clear that sometimes it does, and sometimes it doesn't. So really the question is, does a request to die constitute one that should be respected by aiding, or merely respected by not interfering? If you think that it should only be respected by not interfering, then you wouldn't think that physician-assisted dying or voluntary active euthanasia are justified. What's justified if a patient wants to die is to send them home so they can kill themselves. On the other hand, if you think that it needs to be respected by aiding, then you might think that either physician-assisted death or voluntary active euthanasia, or both, would be justified. Also, is there a morally relevant difference between not saving a life or removing life-sustaining treatment and actually intervening to cause death? You can think that some instances have important differences, but those may be due to things like consent or the person's motives. But what we want to know is, does the mere fact that one is called killing and the physician is causally responsible for it in some way, and one is called letting die, change anything morally? Finally, to what extent can physicians be involved, and does the extent of their involvement alter the morality of the action? Many people who argue in favor of physician-assisted death, but against voluntary active euthanasia, do think that the extent of involvement matters. And while voluntary active euthanasia requires too much involvement, physician-assisted death does not. And so physician-assisted death fits within the role of the physician, but voluntary active euthanasia does not.